Dr. Sanju from Amardeep Eye Hospital, Kollam, along with Dr. Arya as mentor and Dr. Swati from Delhi for the discussion. Sorry,
Dr. Jaya. Yeah.
Dr. Jaya. I'm sorry. And without much introduction, I hand over to Dr. Marian, who is the course coordinator of this program. Over to Dr. Marian.
Yeah, thank you so much. This is our fifth module, as Dr. Bastic has already told. With great pleasure, I welcome Dr. Jaya. She is the examiner for today's session. I know Jaya from my fellowship days. She was a clinical senior research associate with the Holiday Institute of Medical Sciences after post-graduation. Then she did Cornell Fellowship from Shankar Nethralaya, Chennai. And now she is working with Healing Touch Eye Center in Delhi since almost more than 10 years now. And she has got lots of experiences regarding all the corneal pathologies. Then I welcome Dr. Jaya. Yeah. I welcome our student Dr. Sanju and mentor Dr. Arya for this PG classroom meeting. So now let us start.
Yes, ma'am.
Yes.
Good evening, ma'am. Am I audible?
Yes.
You're audible.
Yes.
Is the slide visible?
Yes.
Okay, shall I start, ma'am?
Yes, go ahead.
Good evening, one and all. Coming to my case presentation. 54-year-old female housewife coming from Kollam came with presenting complaints of pain, redness, blurring of vision, difficulty in looking to light in left eye since 1 week. History of presenting complaints. Patient had a history of fever and headache with rashes over the left half of forehead, tip of nose and frontal part of the skull 6 months back. Patient was on oral antiviral medications. 3 days after the onset of infection, patient developed pain, redness and blurring of vision with difficulty in looking to light in the left eye. Patient consulted a local hospital and was on topical medications and symptoms got relieved. Since then, the patient gets recurrent episodes of same ocular symptoms, that is about 4 episodes in the last 6 months. Symptoms gets relieved on taking oral and topical medications and gets aggravated on stopping the medicines. She was using tab acyclovir, loteprednol, prednisolone, homatropin and ganciclovir gel. Pain was insidious in onset, dull aching in nature. Patient also complains of blurring of vision in the left eye, that is for both near and distant vision, and it was progressive. There was no history of any ocular trauma or ocular surgery done in the past. No history of use of contact lenses. No history of any discharge from the left eye. No history of any transplantation, malignancy or immunosuppression. No history of any joint pain, joint stiffness or back pain. No history of any floaters or flashes of light. Coming to past history, she had an history of chickenpox infection at 4 years of age. History of systemic hypertension since 4 years on treatment. No history of diabetes mellitus, dyslipidemia, coronary artery disease, hypothyroidism, chronic kidney disease or chronic liver disease in the past. Family history, no significant family history. Personal history, she takes a non-vegetarian diet, normal sleep and appetite, normal bowel and bladder habits. Coming to general examination, patient was conscious, oriented to time, person and place, moderately built and nourished, pulse rate 72 per minute, BP 130 by 90 millimeters of mercury, no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy and pedal edema. Systemic examination, all the 4 systems at CNS, respiratory systems, cardiovascular system and GIT was within normal limits. Local examination. Head posture is normal. No facial asymmetry. Few old scars of skin rashes following the infection was seen on the left half of the forehead. Ocular posture orthophoric. Extraocular movements was free and full. Coming to the examination. Examination of right eye. Visual acuity. Unaided visual acuity, distant vision 6/9 and near vision N8. Refraction was done and distant vision with +1 diopter sphere. The best corrected visual acuity was 6/6 and near vision add of +2.5 diopter sphere. The near vision was N6. Eyebrows normal in position. Eyeball orthotrophic position and alignment was normal. Eyelids, lid position, both upper eyelid and lower eyelid positions were normal. Lid margins, upper eyelid and lower eyelid margins normal. Eyelashes normal. Skin over the eyelids was normal. Palpebral fissure height 10 millimeters, width 28 millimeters. Lacrimal puncta appears to be visible and everted. Rho+ was negative. Conjunctiva, bulbar, palpebral and fornicel conjunctiva was normal. Cornea, normal shape, transparency was present, sheen present, surface is normal. Corneal sensations were normal in all 4 quadrants and center of cornea. Anterior chamber, normal in depth and clear contents. Iris, brown in color, normal pattern with no transillumination defects. Pupil, number 1, round shape and size was normal. Light reflexes, direct light reflex and indirect light reflex was reactive. Accommodation present. Lens normal. Fundus, distant direct ophthalmoscopy, red glow present. On 90-day examination, media appears clear. Optic disc size, vertical 1.8 millimeters and horizontal 1.7 millimeters. Shape, vertically oval. Color, yellow-orange. Neuroretinal rim appears to be normal. Vessels were arising from center and branching dichotomously. AV ratio 2:3. Peripapillary area normal. Foveal reflex normal. Macula normal. Coming to the examination of the left eye. Visual acuity, unaided distant visual acuity 6/60 and near N18 blurred. After refraction with +1.25 diopter sphere, the best corrected visual acuity is 6/36 parts and near vision add of +2.5 diopter sphere. It is N10. Eyebrows normal in position. Eyeball orthotropic position, normal alignment. Eyelids, upper eyelid and lower eyelid position is normal. Lid margins, upper eyelid and lower eyelid margins are normal. Eyelashes normal. Skin over the eyelids, few scars of old rashes present in the skin over the upper eyelid. Palpebral fissure, height 10 millimeters and width of 28 millimeters. Lacrimal puncta appears visible and everted. Rho+ negative. Conjunctiva, in bulbar conjunctiva, there was mild conjunctival congestion. Palpebral and fornicel conjunctiva appears to be normal. Cornea, shape was normal, transparency absent, sheen absent, and the surface of the cornea shows a central, irregular, fine epithelial defect in an arborizing pattern with tapered ends. Base of the defect was staining with fluorescein dye, and small pigmented lesions of uniform size distributed along the endothelial surface of central cornea, suggestive of old KPs were found. Corneal sensations are reduced in the entire cornea. This shows the diagrammatic view of the epithelial defect and the slit view showing the old keratic precipitates and the epithelial defect. Anterior chamber.
Sanju, just a small question. Yeah. So just a small question. So this examination when you have when she's presented you is after how many months of the primary infection?
6 months, ma'am.
Oh, so in between she is consulted elsewhere.
Yes, ma'am. She was consulting a local ophthalmologist and she was on medications. But since it was
Yes.
recurrent, she was referred here.
Yeah. Go ahead.
Okay, ma'am. Anterior chamber, normal in depth and clear contents. Iris, brown color, normal pattern, and there was no transillumination defects. Pupil, 1 in number, round shape, normal size. Light reflexes, direct and indirect light reflex were reactive, accommodation present. Lens, normal. Fundus, red glow was seen hazily. And on 90-day examination, it was a hazy media and the disc and macula was seen hazily. This was the anterior segment photo of the lesion and the slit beam photo.
One more question. Like, did you do the rose Bengal staining also?
Ma'am, pardon?
Rose Bengal staining. This is a
No.
fluorescein staining.
Yes, ma'am. I have done only the fluorescent staining. Didn't do the rose Bengal.
Hmm. So you know, na, what is what stains what? Fluorescein
Yes, ma'am.
stains what? So I think your mentor is Arya, right?
Yes, ma'am.
Yes, ma'am.
Yeah, yeah. No, I'm just saying in case like you should, basically you have guided her for the case, na?
Yeah, okay, ma'am.
Yeah. Go ahead. Go ahead.
This is a fluorescent staining of the epithelial defect.
Better zoom.
Case summary.
That so
Pardon, ma'am?
that was the original presentation with the
Yes, ma'am.
where you're seeing this dendritic pattern. The stain
Yes,
is
ma'am.
not actually the stain is not actually a very good dendritic pattern. So okay, go ahead. Go ahead, Sanju, please.
Okay, ma'am. Okay, ma'am. Case summary. 54-year-old female housewife from Kollam came with complaints of pain, redness, blurring of vision, and difficulty in looking to light in left eye since 1 week following a viral infection. Patient had history of chickenpox infection at 4 years of age. On examination, visual acuity distant 636 parts and near ended. Mild bulbar conjunctival congestion was present. Cornea shows a central, irregular, fine epithelial defect in an arborizing pattern with tapered ends. And the base of the defect was staining with fluorescein stain. All pigmented keratic precipitates seen deposited on the endothelial surface of the cornea, and corneal sensations were reduced. Diagnosis, dendritic keratitis, possibly a herpes zoster ophthalmicus in left eye, simple hypermetropia both eyes, and presbyopia both eyes.
Okay. So it's not just dendritic keratitis because you're saying there was photosensitivity. It is like you've got the keratic precipitates. So
Yes,
it's
ma'am.
more of a keratouveitis. Do you get my point, Sanju?
Ma'am?
Do you get my point? Because it's
Yes,
not
ma'am.
just
Yes, ma'am.
dendritic. The, see, the photophobia, the endothelial, you're saying that they were keratic precipitates.
Yes, ma'am. They were all pigmented KPs were found, ma'am.
So I would label it as keratouveitis,
Okay, ma'am.
not dendritic alone.
Okay, ma'am.
Hmm. Because in the Marina, actually I didn't get the concept. She has a mentor, so the mentor is supposed to like ask her the questions or
No,
tell.
no, no. You can ask the questions to her, and you are the primary discussant.
Okay, I'm the primary discussant. I thought that the mentor will also be discussing
No,
along with.
if mentor can add on to it, but you are the primary discussant. Yeah.
Okay. So you've read about the differences between the dendrite pattern of herpes zoster and herpes simplex. Did you
Yes,
go
ma'am.
through it? So tell us that.
Ma'am, in a herpes simplex virus keratitis, there's a dendritic pattern wherein which the dendrites appear to be in a medusa head pattern, and it's more deeper. It's more deeper with a terminal bulb present.
Yeah.
While in case of a herpes zoster ophthalmicus, it is a pseudodendrite where the dendrites are actually much more smaller, and it is having a elevated surface without any terminal buds, and the ends of the dendrites will be usually tapering ends.
Yeah, that's good. That's nice. I would say that from next time you also do a rose Bengal staining on top of the
Okay.
fluorescein staining. That would also help you.
Okay.
Okay. So what is your plan of action for this patient?
Uh, since it is a proven case of herpes zoster, we can first start with the debridement of the corneal ulcer, followed by giving topical antiviral medications,
Debridement.
local debridement, in order to reduce the viral load so that there's a better penetration of the topical drugs that we are adding on.
Not so. We don't do debridement of any dendritic corneal ulcer. Is that the practice pattern there? Marian, do they routinely do debridement of
No,
dendritic?
no, never. No. It is a
That's
clinical
it.
diagnosis. Yeah, clinical diagnosis and start the treatment.
Yes,
Okay.
absolutely. So we don't do debridement. We straight away, like if it's a dendrite, what should you avoid? Why do we stain? If there are any epithelial lesions, whether it be herpes simplex or herpes zoster, so what do we avoid and what is the primary treatment?
Primary treatment is topical antiviral medications, and we have to avoid
Yes,
topical
like that.
steroids.
Yes, you're absolutely right. So you must avoid the steroids in these epithelial lesions because this is a keratouveitis. Maybe this has got complicated because since 6 months, it's already 6 months. So she's
Yes.
having recurrent episodes. But in my experience, let me add this that usually herpes zoster patients, herpes zoster ophthalmicus, they usually present with uveitis. The epithelial lesions in herpes zoster is much lesser.
Okay, ma'am.
But this your patient, if you're saying that was having dendritic, so it's there in the picture. And so what else? So once the epithelial lesions heal, then you're supposed to add the steroids.
Yes, ma'am.
So what was the topical and antiviral that you start the patient on?
3% acyclovir was started, ma'am, 5 times daily.
Yes. And usually, did you follow up this patient? Like, have you seen her after the treatment?
Yes, ma'am. I've seen her after the treatment. After about 1.5 weeks, she came for a review, and actually the dendrites were resolving in a resolving state.
Yes, very right. Actually, these dendrites they resolve quite fast. In fact, even in 3 days, you'll be noticing that they have almost gone. But we are supposed to give the ointment at least for 3 weeks. You're aware of this?
Yes, ma'am.
And subsequently, then did you start the steroids?
Yes,
And
ma'am.
what about?
After about 7 to 10 days after the first review, we started on a mild topical steroid also.
Correct. And what about the oral antiviral?
Oral antiviral, ma'am, since I was started like oral acyclovir was given 800 milligrams 5 times daily for about 7 to 10 days was given.
See, this will differ. Maybe your consultants over there or the doctors over there, in herpes zoster ophthalmicus, or not in the acute phase, because now it is 6 months down the line. So I would just give 400 milligram 5 times a day. In the acute phase, when the rashes have come in herpes zoster, then we give 800 milligram 5 times a day for 10 to 14 days.
Okay, ma'am.
So what is, like, I mean, any difference of practice pattern from us and there? Because
No,
now
it's
also you,
basically the standard is to give, I think, 800 milligram 5 times per day for 1 week.
in the acute phase, yeah, in the acute phase, when the patient has had
Yes.
that
Yeah.
rash in the acute.
Yeah.
But if it's a recurrent thing, like supposing if the patient is having it recurrent, then 400 milligram
Yeah.
5 times a day as the therapeutic, and
Yes.
prophylactic is 400 milligram twice a day. And
Yeah.
that
Correct.
400 milligram twice a day continues for continues for long.
Yeah.
So
6 months
any blood,
sometimes. No?
yeah, more
Sometimes
than 6.
6 months.
Yeah, even sometimes some patients you have to continue it for a year, more than a
Okay.
year. And, like, so where's the virus residing, and basically you said because there's a rash in the forehead. So can you explain the general dermatomal distribution, or about this herpes zoster,
Yes,
Sanju?
ma'am. Herpes zoster occurs after after chickenpox infection, where the virus will be dormant, remaining dormant in the ganglion as well as in the dorsal root. So in this case, the forehead, it's the left side of the forehead, along with the frontal part of the skull and the tip of the nose was involved. So if the
So what is the sign called as? What is the sign called
Hutchinson
as? Tip
sign,
of the nose.
Hutchinson
What is
sign,
this
ma'am.
sign? Correct. Very nice. So whenever you see a herpes zoster ophthalmicus and you see the tip of the nose being involved, then very likely that the ocular symptoms will develop. In
Yes,
the
ma'am.
acute phase, I'll tell you, in the acute phase of herpes zoster ophthalmicus, mostly you'll see patients with blepharoconjunctivitis. The lids are also swollen, the conjunctiva looks red, and often when you will stain in the acute phase, you will not see anything on the cornea. The cornea is practically clear. Okay, so this happens later on. So my dictum is that if I see a patient having involvement, tip of the nose or side of the nose, that's having a vesicle, then I would continue the patient on oral antiviral for a longer time.
Okay, ma'am.
Hmm. So what about when you're keeping the patients on acyclovir? What test should you do routinely?
Pardon, ma'am.
So anything about the drug toxicity that like when you're keeping the patient on acyclovir, which blood test do we ask for? Got my question? Got the
Yes, ma'am. Sorry, ma'am. I don't know the answer.
okay? That's yes. So every 3 months, if the patient is a long-term prophylactic dose of acyclovir, even if it's 400 milligram twice a day, you must get the renal function test and the liver function test done.
Okay, ma'am.
Because see what happens, who are the patients who actually get affected with this virus? Like you said, it's there in
Immunocompromised
our,
individuals.
yes, immunocompromised, diabetic people, older people. Okay, so you must get every 3 months. What we do is we ask for the kidney function test.
Okay, ma'am.
Important, that's important.
Okay, ma'am.
Anything anything else, Marian, you would like to add? Any more questions? So you read about the this herpetic eye disease trial, etc.
Yes, ma'am.
Heads one, heads two.
Yes, ma'am.
So what was said over there? Though these are
Uh,
all now old studies, but still, for exam point of view,
yes, ma'am.
they are important. So what did
There
you
were two
understand?
studies of heads, that is herpetic eye disease study 1 and herpetic eye disease study 2. And under each studies, there were three clinical trials being put forward. So in the heads 1 study, the first trial was heads SKN study. That is those patients who was having a herpetic stromal keratitis who were already on topical trifluridine were started on topical steroids, that is 1% prednisolone, and they found that the stromal keratitis was resolving quickly and there was no progression of the disease. That was the inference of the first clinical trial. The second clinical trial was HEADS SKS study, that is those patients who are having a herpetic stromal keratitis who are already on topical trifluridine and topical prednisolone was put on oral acyclovir, and they were finding if the oral acyclovir was efficient enough in order to control the stromal keratitis, but the study proved that there is no effect for the oral acyclovir in case of a stromal keratitis disease. And the third clinical trial was a HEADS IRT trial, that is for patients with herpetic iridocyclitis and who were already on the topical steroids and topical trifluridine, was started on oral acyclovir, and they found that there was an effective control of the disease. That was the third clinical trial under HEADS 1. Then HEADS 2, the first study was HEADS EKT study, that is those patients with the epithelial keratitis who were already on topical steroids and topical trifluridine were started on oral acyclovir, and they were just saying if the oral acyclovir can prevent the conversion of the epithelial keratitis into a stromal keratitis or an endothelial keratitis. But the study found that there was no effect of oral acyclovir in such a case, and the oral acyclovir cannot prevent the conversion of the epithelial keratitis to a stromal or an endothelial one. And the second trial under HEADS 2 was HEADS A acyclovir prophylaxis study, that's APT study, where in which they found that if you're giving acyclovir prophylaxis for a period of almost 6 months to 1 year, there was an efficient reduction, that is almost about 50% reduction in the chance of recurrence of the disease. And the last trial under HEADS 2 was about the risk factor study. That is, they were assessing the risk factors to find out if there is any chance of recurrence of an epithelial or a stromal keratitis in the long run.
Good, very good. That's nice. So, apart from oral acyclovir, what are the other drugs and what is the dosage?
Or valcyclovir can be given, ma'am, oral valcyclovir. If it is a dendritic keratitis, we can start with 500 milligrams BD dose. Or if it is a geographic keratitis, we can give 1 gram 3 times daily, can be given for a 10 to 14 days time. And if it is for a prophylactic dosage, then the dose will be 500 milligram OD for about 1 year can be given.
Correct, absolutely correct. So, this patient, after the resolution of the dendritic keratitis, steroids were started?
Topical steroids were started, ma'am.
Okay. So, which steroid did you start on?
Loteprednol. She was started on loteprednol, ma'am.
Initially, you can start with loteprednol, and as you see the improvement, because sometimes the edema, if it's a keratouveitis or endothelitis, stromal keratitis, the edema is very bad. So that will only resolve with a very high-end steroid,
Important.
more potent
Yes.
steroid. Lotepred, fluoromethalone, these are quite these are soft steroids, only acting on the surface. So quite often we have to start the patients on Dexa or prednisolone as we see what the condition of the cornea. Okay.
Yes, ma'am. Yes, ma'am.
Can you name an instrument with which you can objectively test the corneal sensations? You
Is
got
the
the
issue?
question? Correct. Do you know the name, the classical name of the aesthesio?
Sorry,
Okay,
ma'am.
that's okay. There's a very famous pocket bonnet aesthesiometer. Okay,
Okay,
just look
ma'am.
it up.
Okay. Okay, ma'am.
Otherwise, we just take a wisp of cotton and
Okay.
we then do the test. You you look for the corneal sensations yourself.
Yes, ma'am.
So how do you test it otherwise?
Ma'am, I tested it using a wisp of cotton, and I tested it from the lateral sides as well as from the center, and all the four quadrants were also tested, and it was
And
seen that there was a reduction in the corneal sensation in the entire cornea.
mm, and the patient looks straight. The gaze is straight,
Yes, ma'am.
right?
Yes, ma'am.
So, anything else from your mentor? So, Marin, are they from your hospital or they're from a
No,
different
no.
place?
They are from a different
Huh?
place. They are from a different hospital.
Okay, so it's a, like the Kerala Society, like
Yeah,
what
Kerala
we,
Society. Every
you're in
second
which?
and fourth Mondays.
Okay, every
Every 2 weeks, once in 2 weeks.
the classes are conducted.
Yeah,
Very
yeah.
nice. So you're in which year? Sanju is in which year?
She's first year.
First year, ma'am.
Oh, that's very nice. She knows the heads so nicely in her first year. So did this case presentation help you, Sanju?
Yes, ma'am.
Good. So though this was a case of herpes zoster, like in herpes simplex, can you tell us like the different presentations if it's a herpes simplex keratitis? What do you see
Ma'am,
in the epithelium? What do you see in
epithelium,
this?
there can be a infectious one as well as the non-infectious one.
Correct.
Infectious ones are starting with a vesicle, then it can be a dendritic keratitis or a geographic keratitis, or it can even be a marginal ulcer. Then a non-infectious one include neurotropic keratopathy. Then in the stroma, there can be a stromal keratitis with an ulceration like a necrotizing keratitis, or it can be without an ulcer like non-necrotizing keratitis or even interstitial keratitis. And in the endothelium, it can be a disciform keratitis or a diffuse keratitis.
Dr. Jaya.
Oh, sorry. I didn't realize I had muted. I'm
Yeah.
so sorry. So what I was saying that in the stromal, it can be both immune stromal or it could be stromal necrotizing. Stromal necrotizing means that the viruses are actively replicating over there.
Yes,
So if it's a stromal necrotizing, and then you have to be very very careful. Whereas if
yes,
it's an immune, you need to put the patient on steroids.
yes, yes, ma'am.
So what about neurotrophic? Though you're just in first year, so I don't think you very right to ask you so many questions. But what I was asking about neurotrophic. Have you seen any neurotrophic ulcer?
I've not seen yet, ma'am.
So you've read about it. What is it about? It's like a
Uh,
non-healing corneal ulcer.
Non-healing recurrent ulceration, ma'am.
Correct, correct. So it doesn't heal, right?
Yes, ma'am.
So there are different ways you will gradually learn how to treat a neurotrophic ulcer, what is
Yes, ma'am.
supposed to be done. So in the course, I think you'll be knowing it better. So Arya is like, I mean, a consultant in a hospital or she's a senior resident?
Yes, ma'am. I'm junior consultant at Amadhi Hospital, Kollam, ma'am.
Okay, okay. So you could add something,
Yes,
your student,
sure, ma'am.
anything, yes.
Yeah, ma'am. Dr. Sanju, can you please mention about the intraocular pressure in this patient? Was it
Yeah,
normal?
that
It was within normal limits, ma'am.
Okay. Can the pressures be high in such cases? Can you please explain the mechanism, how it is, how it can happen?
so basically, in the clinical manifestation, Sanju, like what we were just discussing,
Yes, ma'am.
epithelial, stromal. So there's something else as well. These patients can have trabeculitis.
Okay, ma'am.
So in such cases, if patient develops glaucoma, which are medicines, which are anti-glaucoma medicines you are supposed to avoid?
prostaglandin analogs should be avoided.
Okay. One more.
That's right. PG analogs should be avoided.
And also, you have mentioned about the keratic precipitates. So, you must be knowing the different types of keratic precipitates and at least two conditions for each of them. Can you please mention few?
Yes, ma'am. Keratic precipitates, small fine keratic precipitates are seen in non-granulomatous uveitis, and with more larger keratic precipitates are seen in granulomatous ones, like as in sarcoidosis, mutton fat KPs can be found. And usually the keratic precipitates are found in the inferior quadrant in an arched triangle, but in Fuchs heterochromic iridocyclitis, diffuse fine KPs are found.
What is the nature of the keratic precipitates in herpes?
Small
So,
fine keratic precipitates.
no, I would disagree. Uh, they are not small fine. In fact, they are mutton fat keratic precipitates. So listen, I'll just tell you of a condition. For example, a patient whose cornea has got decompensated because of repeated viral keratitis episodes, whatever. Like it cannot be epithelial, but recurrent stromal episodes or endothelitis. So the patient's cornea has got decompensated. So the patient undergoes, for example, a keratoplasty. It can be a full thickness penetrating. It can also be just a lamellar keratoplasty, right? So in
Yes,
the later phases, supposing if the patient, this is a little tough question for you, but still, I'm just explaining so that somewhere you may come across such a situation. So the patient undergoes a keratoplasty, and later on they develop these sign symptoms which are suggestive of both an acute graft rejection as well as recurrence, because you know that viral keratitis can recur. It can recur again and again. Your patient has got the fourth episode, I believe, right?
yes, ma'am. Yes, ma'am.
So how would you differentiate such a situation, whether it's a graft rejection that the patient is having or it is a recurrence of the viral keratitis? So maybe you can save this question, and as you go ahead, progress in your clinical journey. No, it's not just the Kodadost line who's written this. It's not just the Kodadost line. So basically, I'll tell you from our clinical experience, when we
Yes,
see very large keratic precipitates like mutton fat keratic precipitates, then we think more in terms of viral recurrence.
okay, ma'am.
Okay, and when you see the keratic precipitates, that is much more as compared to the eye, which has got the cellular reaction is less. Understand, the cellular reaction AC cells will be less, but absolutely large mutton fat keratic precipitates, if you are noticing, then it's in favor of a viral recurrence.
Okay, ma'am.
Okay, so you need to start the patient on full therapeutic dose of oral antivirals, right?
Okay, ma'am. Okay, ma'am.
Anything else, Marian? Anything else would you like to add to them?
No. How will you follow up this patient? Like, this is a clear-cut case
Yeah,
of, yeah. How will you follow up
recurrence.
this patient? And in each follow-up, what all things will you look for?
Ma'am, in each follow-up, we have to assess the visual acuity of the patient, the
Mm.
intraocular pressure,
Mm.
and in the slit lamp examination, we have to see how the epithelial defect is regressing or not, and if there is any inflammation in the anterior chamber, like if there is any cells or blood.
So, suppose the vision drops and you think cornea is healing, then what are the other differentials that you keep in your mind? Cornea is started healing, but vision is dropping. So, what are the things you will look for, or will you keep in mind? You can think about the complications of episodes of ophthalmicus in each or in each segment of the eye.
Oh, okay,
Yes.
ma'am.
There can be myriad manifestations of
Yes.
herpes zoster
Yes, ma'am.
ophthalmicus. That's a
There can be
complete
posterior
chart.
pole manifestations also.
Pardon? I couldn't get it.
Posterior pole manifestations like
Yes, yes.
choroiditis or retinal detachment, even a tractional retinal detachment can also occur.
I mean, before that, directly tractional retinal detached, we can get acute retinal necrosis.
Yes, ma'am.
Yeah. Then, I mean, before that, in the anterior segment, already we have discussed uveitis, keratitis.
Yes, ma'am.
Then raised IOP, corneal edema due to trabeculitis.
Then there can be
And this patient, this is the fourth episode now. We'll be
yes,
getting
ma'am.
multiple episodes. The patient was getting recurrent steroids also, no?
Yes, ma'am.
Yeah. So,
Cataract formation.
yeah, yes, yes. So patient can have posterior subcapsular cataract. Then in the posterior part, you can get acute retinal necrosis and what else? You can get optic neuritis also.
Yes, ma'am. Optic neuritis.
Correct. One simple thing that I would like to tell you, often, like if you don't know whether the patient had herpes zoster in the previously or not, and but when you see in some patients iris atrophic patches, they are pointers of a past herpes zoster infection.
Yes, ma'am.
Got my point?
Yes, ma'am.
They can also land up with optic atrophy, herpes zoster patients.
Anything? Dr. Arya, would
Anything
you
else
like
to
to
say?
add something?
No, ma'am. Almost all point has been covered, ma'am. Nothing from my part, ma'am.
Yeah, a
Maybe
few
Arya can
points.
also switch to her video.
Okay,
Yeah,
ma'am. Sorry.
I think it was a good discussion.
yeah. And Dr. Sanju, yeah, in the history you were telling about no history of surgery. What surgery you mean, and how is it relevant in this case?
Ma'am, certain ocular surgeries can predispose to infectious keratitis, refractive surgeries.
Okay. Okay.
So, when would you like to see such a patient and you see cataract in these patients? So, when would you like to operate upon the cataract of these patients? Who've just had an episode or is having, or even if say that a patient, like it has happened many times with all of us, it's a total white cataract, it's a total cataract, and the patient has suddenly come to you with herpes zoster ophthalmicus. You're seeing the full blown picture of rashes. You didn't describe the rashes in herpes zoster ophthalmicus, Sanju.
Pardon, ma'am?
The rash, the pattern of the rash in herpes zoster ophthalmicus.
Ma'am, initially, it's having a erythematous base with maculopap. Its beginning is with a maculopapular rash, and within about 2 to 4 days, it is converted into vesicle, and the vesicles will become confluent, and then it can be converted to a pustule and even a crust.
Yeah, very right. So, did you get this question of when would you like to operate the cataract of these patients?
After the crust is formed, I mean, nearly almost the lesions are crusted. That is at the end of the infective phase.
So, according to you, how much is that?
2 weeks time, five
No.
days after the rashes have been crusted.
So, let's ask your seniors over there. Marian, do you operate in 2 weeks' time?
No, no, no. Now you can ask the senior. I mean, other.
Yes. Senior. Yes, let's know the opinion of others. Arya, do you have to say something? Arya is there or not there?
Yes, ma'am. Yes, ma'am. No, ma'am. Usually we don't operate in 2 weeks' time, ma'am.
Yes, very true. So, Sanjay, you get the point that it not in
Yes.
2 weeks' time. You need to wait till the eye is absolutely quiescent. Okay,
Okay.
and I would
Okay.
not touch such an eye until and unless if it's a total cataract. Maybe there the decision can vary. where supposing if the eye is going into phacomorphic, phacolytic sort of thing. Otherwise, not before. Like I would not operate these eyes even 3 months.
Yes, exactly.
eye has to be, the eye has to be totally quiet. And when you are going to operate these patients, you have to give them the prophylactic dose of oral antiviral. Otherwise, it may again recur. And we've had cases where accidentally, supposing not knowing the prior history, these patients have got the cataract done, and suddenly after the cataract surgery, they come with the uh, recurrence of the viral keratitis.
Okay,
Okay,
ma'am.
because after cataract surgery, you're supposed to give steroids. So when the prophylaxis has not been given, when the oral antivirals have not been started, following the surgery, like you mentioned in your history, the negative history, and Marian also pointed it out that what surgeries. So supposing if the patient has undergone the surgery, the patient's recurrence may happen, and you may have a very large epithelial defect.
Okay, ma'am.
Okay, so
Okay,
this
ma'am.
question is more of practical value. So
Okay,
until
ma'am.
and unless the eye is quiet, you should not operate upon these. Similar goes for keratoplasty. You're not supposed to do the keratoplasty in acute phase of the viral keratitis. When the eye is quiet, then you take them for the surgery with the prophylactic dose. Correct?
Yes, ma'am.
Anything else?
One last question. What's the nerve supply of the cornea? It's very important.
Yeah,
Majority of the examiners are very fond of that question.
correct, correct,
Trigeminal
correct.
nerve, ma'am.
Yeah.
So the divisions,
Trigeminal
the
nerve.
divisions. Trigeminal, yeah. So what's that? The
It's
division of
common four plexus. That is the limbal plexus, the stromal plexus, then the intraepithelial and subepithelial plexus.
You said trigeminal nerve. No, which branch of trigeminal nerve?
yeah. She was explaining, I think, the corneal nerve supply.
Uh, she's there. Which branch of trigeminal nerve? We are discussing herpes zoster only,
So,
no?
yeah, yeah, yeah.
Ophthalmic division.
Yes. Can you be
So you'll
little
read
more
about.
Pardon, ma'am?
Can you be
So you
little
read
more
about.
specific?
Yeah. I mean, Sanju, we are asking you to read about the
Nasociliary branch.
trigeminal nerve divisions. Okay,
Yes.
the nasociliary, ophthalmic. Can you recall?
Nasociliary branch of the ophthalmic division of the trigeminal nerve.
Yeah, exactly.
Exactly.
Then, okay.
Okay, so you read about these divisions. Okay,
Yes.
this is very important. Like, hmm, I think that was a good discussion.
Yes, yes. I think we have
I think
come
mostly
forward
everything.
almost.
Yeah.
Uh,
So, what is the literature that you read, Sanju? Like, you're in the first year, so where did you read all this about the herpes? What is the textbook that you've read?
Ma'am, I was reading a few textbooks as well as journals. I've collected information from journals also, ma'am.
Oh, that's good. Then you can know the, but basic like
yeah.
about the division nerves and everything, you have to read it carefully.
Yes.
Okay,
Okay, ma'am.
so I think we've done a good discussion. Anything else from anyone?
Okay, then I think we will wind up.
Yeah,
So,
we can wind up.
yeah. And so, we have come to the conclusion of this classroom. I hope everybody has learned something from this 45 minutes, 50 minutes discussion. I thank Dr. Jaya for agreeing to be to the examiner and to spend her precious time 1 hour during this time on a Monday. I thank Doctors Sanju and Dr. Arya for this agreeing to be part of this PG class.
Thank you, ma'am.
And
Thank you very
yeah,
much. It was
yeah,
really good participating.
yeah, okay.
And
Thank
Sanju,
you.
you've read quite a lot. That too in your first year.
Yeah.
I suppose I didn't know so much in my first year, so that's very good. Okay,
She
keep
presented
reading.
very well. Actually, she presented in the cornea, all the findings she presented really very well. Case presentation was really good.
Thank you, ma'am.
So
Yes,
thank you so much. Yeah.
yes, yes. This
Okay.
was like a long case, right?
That is a kind of
Okay,
long
good.
case, but
Okay, thank you.
for the exam, mostly going to
Okay,
be short case. Yeah. Okay, thank you.
yes.
Thank you, ma'am.
Bye.
Thank you.